So the commissioning role, commissioning for quality, the measuring, the monitoring and the auditing of services. And key element of the commissioning is the intervening if the commissioning is not achieving the stated goal. And that obviously is around measuring performance and stepping in to take action where appropriate. So how do we know we're commissioning quality? Jim has given us a very thought-provoking talk this morning on what is quality and how we're setting a quality agenda. But how do we know? We can't measure quality in itself, but we can measure standards that reflect quality. And that's probably as near as we will get. And quality is different things to different people. There are the quantitative aspects, and then there are, of course, the more qualitative, sometimes we think of as softer aspects, but they're no less important. And this, I think, is where we have a huge contribution in terms of audit. And of course, most of you in this room will be much more familiar with the detail of audit than I will be, so I'm not going to pretend to teach you on audit in any way. But the issues are very similar to commissioning. We're identifying standards, we're collecting data, we're comparing our standards, we're planning the change, we're implementing the change, and we're measuring again. It is about not so much the process, but the end point of continuously improving the quality of what we do and having that critical eye to measuring what we're doing and recognising that the objectivity of audit helps us improve. Just one for a moment to think about how we view audit. I'm not indicating how we view it, but just to ask a few questions. Is it the party scene? Do we look forward to audit with enthusiasm and celebrate it? Alternatively, does it seem more like an exam? And I know some junior doctors in training may sometimes view audit as something like a viva, and this is maybe not a million miles away. And I think that's really unfortunate because it's such a valuable tool and from which we can learn so much. There's also a tendency of putting audit in one box as something as an add-on and not really integrating it to what we do elsewhere. And all of those, to a greater or lesser extent, I think are very negative aspects around audit and I think fail to recognise its true value and its true contribution. So how can we benefit from audit and ensure that it really does make a difference? We've talked about commissioning for quality, and I would argue that part of that, if not a very large part of that commissioning for quality, should rely on audit and then appropriate action. That there is a natural synergy there between commissioning and audit. I think that if we do robust audits and we do them sufficiently objectively, and regional audits are a good example of that, and I know Damien later will talk about national audits, we have huge amounts of information that can directly contribute to quality improvement. Therefore, I would argue that audit is an essential element of commissioning. If we return just for a moment to look at the commissioning cycle once again, it is entirely feasible to think at every step that there is a role for audit. There's certainly a role for audit at assessing population needs. There's certainly a role in terms of how we prioritise and plan and identify resources. Shaping the market is maybe more action than audit focused. But when we get into monitoring the change and measuring what has happened, I think there's a huge role for audit and a huge role in terms of influencing what happens next, looking at that outcome and planning for the ongoing cycle. The idea of audit and commissioning is not new. I don't expect you to read this. I just put it up by way of example. Back as long ago as 1994, commissioners were building into their contractual relationship with providers audits. And I looked through this list and it struck me that some on this list are equally pertinent today as they were back in 1994. There are two audits here that refer to thromboprophylaxis, And of course, very recently, we've seen NICE guidance on thromboembolism. So absolutely a key issue, every bit as relevant today as it was a number of years ago. And there's also audits around perioperative deaths, a confidential inquiry into perioperative deaths. Again, what we learn around mortality, whether it's maternal mortality or perioperative, is as pertinent today. So here we are, quite in our minds, moved on quite significantly from 1994, but we were doing this in 1994. And I suspect that we've lost it a little bit. We've lost that rigour of building into the contracts the need to audit and measure in order to influence the next contractual relationship with a trust. So what does the future hold? Perhaps shaping audit to reflect commissioning intentions, perhaps shaping commissioning on the outcome based on audit data. But I would like to think certainly quality improvement that is very explicit, that is very evidence-based, and that will truly affect change. So Robin would probably like me to take a few questions, and I'm very, very happy to do that. But let me pose a few questions for all of you this morning. One is, how can we ensure that the future audit programme reflects departmental and health and social care priorities? And how can we ensure that the audit programme and its outcomes will actually result in meaningful change in how we commission, how we deliver, and how we provide services? So maybe the opportunity to stimulate a little bit of discussion around those two issues.
Miriam. Those are two very interesting questions, not complex and very difficult. Any thoughts on those questions or anything else on commissioning that you want to ask?
Miriam, maybe I can say. One of the things that strikes me as important is Jim's quality strategy, which sets a direction, and that's absolutely terrific. And then to avoid having audits on a sort of a knee-jerk response to what's the latest crisis, is it that in intensive care beds, is it delay in getting to fractures, theatre, that sort of thing. And I don't know whether it's possible to have a well thought out audit programme that I would like to have, but it would be nice if things would be stratified as we look for the high cost things and the critically important things, the high volume things, and the way that we actually mind it at the moment. But I don't know if it's possible to do that, but perhaps some of the ideas that just people find in their everyday work in the service, whether it's in social service, whether it's the doctors and nurses, they're just little things that they come across. We've had a lot of benefit, I think, from the audits that we've done in pharmacy and therapeutics, and that's been invaluable. We always do the same thing, we're not really good at it, sadly. But nonetheless, we should keep trying to do that, and I think your point is very well taken. How do we actually affect change? And in a way, if we had focus on things that we can really achieve, and if we have good integration from the department, from the board, and then from the service, and we sort of keep it running. But it may not be very easy to define an absolute mechanism by which we go from basically logically
I appreciate that. I think you're absolutely right. It would be nice, I think, maybe to have a stronger relationship, but the one thing you don't want to have is something that stymies any kind of innovation or original thought. So you don't want to limit that aspect. But one thing did strike me in the quality strategy, I was going to say Jim's strategy, the departmental quality strategy. There is a recommendation around quality reports, that providers will produce quality reports. And I know that that has been done in England over the last 1-2 years maybe. There was a report out a couple of months ago from either the King's Fund or Nuffield that said that while the quality reports were good in themselves, they were so different in their style and content that they weren't comparable. So there was no benchmarking, no sensible amount of benchmarking was possible. One of the things that strikes me that could maybe help would be that if we're commissioning quality reports, that we build into those some element of audit, and try for each year to maybe give a bit of direction without limiting individual organisations around the detail, but that we give some direction about what might be appropriate to provide as a measure, as an audit measure in their reports. Just a suggestion of how we can utilise it. But I do think there's a balance that, you know, we certainly don't want to stymie any sort of creativity and innovation, and yet I think we don't quite maximise the potential of audit. There's lots of good stuff, but we don't necessarily harness it and use it to absolute maximum effect.
Thank you. That was a good overview of commissioning in general for many of us or clinicians.
Can you take the microphone?
Sorry, Damien Fogarty. Well, I'll just speak louder. So my question, Miriam, is really about how can we ensure that the future audit programme best reflects departmental and HSC priorities. History is very important in this, and you've shown us an excellent slide of history of audits in 94, 95 that are still pertinent today. And as I will allude to in my presentation next, if it's important enough to do once or twice, it's important enough to continue doing it. And therefore, we need to build an infrastructure that allows us to do that. But more importantly, as we've seen from general practice, is that you do need to incentivise the providers in some shape or form to actually say, well, it's in our interest to devote time, effort, expertise to ensuring the audit programme. And I would just like you to comment on this, whether you think there's a lack of incentivisation with respect to secondary healthcare compared to primary.
Right, okay. That's a fascinating question. And firstly, I think changing behaviour inevitably does require some degree of incentive. And I would argue with that some disincentive for inappropriate behaviour. What that looks like and what you actually incentivise around and where the financial elements sit is a very tricky one. You know, it was on Stephen Nolan, Jim's favourite programme yesterday, around possible penalties, sanctions they were termed, around A&E performance. And that's very controversial at the minute, but nonetheless that's the environment that we live in. I thought it was really interesting, and I think, Damien, you might have been present for this discussion around quality outcomes, and I think we should probably be incentivising around the outcome and not the process. So, for example, in terms of commissioning in England, I think there are incentives for providers, for example, on renal dialysis, that if they're able to provide renal dialysis to their population, of whom 85% are receiving their dialysis via fistula, they get paid one sum of money per year. If they're providing it to a population where less than 85% are receiving their dialysis by fistula, they get a lesser sum of money. So what the commissioners there are doing are incentivising an outcome that is evidence-based and around quality. They're not incentivising the audit or the collection of data to measure what people are doing, but that's the automatic tool that underpins that. They are incentivising around quality. And I suspect that that's where we need to get to. Unfortunately, that is difficult because we first need to understand how far away we are from those quality measures, how we're going to get there, and what reasonable incentives may be put in place. But I think it's that issue around outcomes which hopefully will drive people to want to do the audit because they'll gain from learning more about their own behaviour. But it's an issue which merits a whole day in itself, I have to say.